I'm still, still on the move here, Wendy.
I heard a pause. I thought I should enter.
I was giving people time to read
Okay.
the disclaimer. Okay. Um, as folks, before you, what you're seeing, what I like to refer to as the profile of a healthy person. And as we always say, health is not really about how you feel or how you look or how people say or how well people say you look. It's really about what you do, how you control your thoughts on a day-to-day basis, what you eat, how you exercise, whether or not you are aware that nutritional supplementation is also important in the diet. But even with these three, even if you did all these three perfectly, because we live in a hostile world, because we're exposed to so many toxins, because anything can go wrong, it is also extremely important for you to understand the healthcare system, for you to understand how to take advantage, how to work of the healthcare system, and how to work intelligently with your doctors. And the only way you can do that is if you are informed. And that is why we have a presenter like we have tonight. And really, it was Dr. Green, who has been on this webinar a couple of times in the past, and 2 weeks ago he spoke about fertility preservation in cancer survivors, and as always, he did an excellent job. And really, it was him, or it was he who connected us with our speaker tonight. Apparently, she was one of his residents during her rotation, and she's going to tell you some more about that. But we're honored to have her on the call and on the webinar tonight. And while we're changing screens, I'm just going to have Sherry introduce our speaker, Dr. Brewster, and we'll just hand over to her. But again, we just want to thank her for being on, taking out of a busy schedule to prepare and to do this presentation for us. Sherry, go ahead.
Okay. Dr. Wendy Brewster is the director of the Center for Women's Health Research. She is a gynecologic oncologist and an associate professor. And Dr. Brewster, like I said, is a gynecologic oncologist in the Department of Obstetrics and Gynecology, and she provides clinical care, performs complex gynecologic cancer surgeries, and treats patients with chemotherapy. She is also a population scientist with a research interest in early detection and prevention of gynecologic malignancies. Boy, that is a mouthful to say. If there's more information about her on our website, if you want to read her more extensive bio, we're very honored to have her on the webinar tonight. So, Wendy, can you hear me?
I can.
Okay. We're waiting for the screen to change to yours, and then we'll hand it over to you.
Okay.
Okay, I can see your screen. If you want to go ahead and do slideshow mode, then we'll be good to go.
Here we go. So welcome, everyone. I am Wendy Brewster. I'm an associate professor at University of North Carolina, Chapel Hill. And I'm a gynecologic oncologist. And so essentially what that means is I take care of women with either complicated gynecological issues, but my real passion is taking care of women who have cancer of the female genital tract. It's really inspiring to be able to work with women such as these. My research interest and the time I spend outside of the operating room is actually spent on research and prevention and early detection. A lot of that is because I know what it takes to cure cancer, and so my philosophy is always prevention is so much better and so much easier than cure. Unfortunately, we don't always know what to do to prevent a cancer or to find it early. So that's where my research is. As director of the Center of Women's Health Research, what I do is facilitate transdisciplinary transdisciplinary research projects. And what that means is getting people from different camps with different perspectives about the problem to approach it. Because gone are the days where only gynecologists should handle gynecological problems. We have so much that we can learn from so many other fields, and it doesn't necessarily have to be fields in medicine. So I spend my time trying to put very different groups of people together just to see if we can get a better perspective on some of these challenging problems. So today, Is that enough? Is that enough introduction? I hope so.
Yes,
but that's good. Okay, so
Yes,
today I'm going to talk about management of the adnexal mass. And I suppose loosely could be called a pelvic mass, but we're just generally going to concentrate on issues related to the ovary. And this is what I'm not sure what experience the participants on the call have, listeners on the call have, but this is what it looks like inside. It's not that color-coded. I wish it was that color-coded. It would make for a whole lot less complications during surgery. But it's so beautiful when you see it. It's just so neatly put together. It's amazing every time you open the pelvis and you see what's there. And the adnexa really are these, when we talk about adnexa, we mean the fallopian tubes, the ovaries. And you can actually see why, if there's a mass in this area, the symptoms can be really nonspecific. If it's large enough, it may press on the bladder, it may press on the rectum behind here, it may press on the side wall, and you may get clots or difficulty that way. The ureter, which brings urine from the kidney to the bladder, comes down here, so it's not uncommon to have evidence of renal obstruction. And so the symptoms of a pelvic mass can be quite variable. Additionally, a pelvis can contain quite a bit, and so it's not, we all hear stories about women who didn't know they were pregnant until 5 months, 6 months, 7 months, because it's a very accommodating area. And so masses can get really large before women notice any symptoms. And so the purpose of this discussion is going to talk about the differences in management of adnexal mass between premenopausal and postmenopausal women. And we're also going to talk about when you have a mass, how you decide what characteristics of that mass make it suspicious for cancer. And importantly, we're going to talk about what sort of surgery is required when somebody has an adnexal mass. Gone are the days where we just took everything out. This is 2009, and we're a whole lot more specific about what's removed. And then early in the discussion, I'm going to briefly talk about adnexal mass in pregnancy. So when somebody with an adnexal mass appears, part of the issue is figuring out how urgent is this condition. Does it have to be done immediately? Is there time to wait? Unfortunately, if the ovary, we don't really have a good test for it. We don't have something like the Pap test that will help us figure out whether something is cancer or not. And so we're sort of, always in the limbo. How quickly should this be addressed? Part of the issues with management and evaluation is to relieve symptoms. I mentioned a host of conditions that can be associated with a pelvic mass, and those obviously are the symptomatic issues that have to be addressed. But we have to decide what's the best way to approach this surgically. We're living in the 2009, and no longer is every mass treated with an excision on the abdomen. Very often, we try to do it in what we call, conservative, in some sort of conservative surgical approach. And then for those women who unfortunately have cancer, we have to determine what needs to be done. And this can be a pretty challenging decision, because you may not necessarily be in a situation where you have all the specialists around to take care of a particular problem. And it's oftentimes responsibility of the gynecologist, who, when they've identified somebody who can come in to help with a problem, you have to tell that person. For example, if you ask a urologist for assistance or you ask a general surgeon, they're going to need to know exactly what you want done, because they're not the GYN oncologist. They won't necessarily be aware of that. Oh dear, I don't seem to be able to advance. Oh, there we go. So when we think about adnexal mass, I know we were talking about cancer, but not all masses in the pelvis will be cancer. And in medicine, we use the word mass, tumor, lesion, and these terms are used when we don't know exactly what it is. And so if we know something is a cancer, we'll say it's cancer. If we know something is benign, you'll say a benign mass. Usually, though, you don't know that these are benign or malignant until they've been removed. So quite often, until you actually have a specimen that you give to a pathologist, you're really going to be stuck calling it a mass, a tumor, or something like that. And so the gynecologic things that it could be is a functional cyst, and a functional cyst really means it's something related to the everyday function of the ovary. So it could be a corpus luteum, or it could be, a large follicular cyst. It could be a leiomyoma or fibroid. You can get those of the round ligament. You can actually get leiomyomas of the uterus also. Endometriomas are not uncommon, and endometriomas can be very difficult on occasion to distinguish from a malignancy because they can have a very unusual appearance. Tubo-ovarian abscess is a possibility. Ectopic pregnancy, mature teratoma, serous cystadenoma, mucinous cystadenoma. So the gynecologic differential is pretty extensive. But there are also non-gynecologic causes of a pelvic mass. In older women, diverticular abscesses are not uncommon. If it's a right-sided adnexal mass, it could be an appendiceal abscess or an appendiceal mucocele. You can have nerve sheath tumors and the dreaded pelvic kidney. You have a mass, you start resecting it without realizing you're actually resecting a pelvic kidney. And so these are things that you have to be mindful of when you're evaluating a pelvic mass and determining what's your approach going to be. When we speak about, as an oncologist, you have a differential diagnosis. In medicine, you don't ever just pick one thing that may be the answer. You're always expected to have a host of things that you're considering as possibilities. And so we have a differential diagnosis, and we'll have a benign diagnosis and a malignant diagnosis. And gynecologic, these are the issues related to the ovary. And it can also be a pedunculated uterine sarcoma or malignant degeneration of a uterine fibroid. And non-gynecologic, it could be a colorectal cancer, a retroperitoneal sarcoma, gastrointestinal stromal tumor, and metastases. The adnexa are sites that have a propensity to be accepting of metastatic disease from anywhere in the GI tract, metastatic melanoma, breast cancer. So these are things that you have to be mindful of. You never just walk in there with just one possible diagnosis. And there are other things when somebody has a pelvic mass, more likely than not, you'll have an ultrasound. At least this is what's common in the United States. And the characteristics of the vaginal ultrasound are very important. And if the woman's premenopausal, it's very important to know what phase in her cycle she's in, because if she is between days 1 and day 10, you really shouldn't see there's no functional cyst that's going to be complex. If you see a complex adnexal mass in the first 14 days of the cycle, it's probably not a functional cyst. It's going to be dependent on age. We're a whole lot less tolerant of adnexal masses in older women than younger women. Physical findings are very important, and in the news there's been a lot of discussion about the signs and symptoms of ovarian cancer. And the signs in women with ovarian cancer will often report that they've had symptoms for a while. The symptoms, though, can be very nonspecific. It can be some bloating, back pain, changes in bladder function, changes in rectal function, swelling in the leg, change in appetite. Not necessarily one thing that makes it likely to be able to give you the diagnosis, but certainly you have to ask those questions. Weight loss is a common one. Family history is extremely important, particularly family history of premenopausal, breast, colon, and ovarian cancer diagnoses. And then there's also CA-125, and that's a challenging test to use, and we'll speak about that a little later. We'll speak more about that a little later. And so at the time of the vaginal ultrasound, the things you want to know is, number one, is it a simple cyst? And if it's a simple cyst and it's a premenopausal woman, you can probably wait to see if it resolves. If it's more than 8 centimeters, you want to figure out how you're going to remove it, because one of the concerns is going to be torsion or twisting on itself, and if it were to do that, it may compromise her entire ovary and tube on that side. And a woman's still desirous of pregnancy later. You don't want to be in that position. If it's a postmenopausal woman and the cyst is less than 5 centimeters and it's not changing in size, you just leave it alone. A solid mass is important. Solid masses, we always remove them because you're really not sure what it's going to be. Complex masses, and these are cysts or masses within the adnexa that have solid areas, excrescences, septations, or ascites. This can be very concerning. Now, ascites, it's not uncommon at the time of ultrasound to see a small amount of fluid within the pelvis. And dependent on the time of the cycle, there may be more or less. But if there is moderate volume ascites or large volume ascites, in any woman, that's not a normal finding. And so that's probably the most concerning associated finding in someone with an adnexal mass. And later on I have a slide that actually shows a complex mass. So let's firstly just talk about the adnexal mass in pregnancy, because this is probably the one that causes the most distress. The worst thing is a woman who's sort of embracing her upcoming birth of her child, and then she's told that she has an adnexal mass, and she has to make the decision about what she does to address the mass, with full knowledge that the actions that she and her physician decide on may compromise a desired pregnancy. And most women will do just about anything to protect their pregnancies, even in the face of very disturbing news. The good news, though, is that the prevalence of an adnexal mass in pregnant women is really, really low. So although this is an uncomfortable position for anyone to be in, it doesn't happen that commonly. And when it does, they're usually teratomas or paraovarian cysts. And very often these cysts are functional and they'll resolve as pregnancy continues. Malignancy is diagnosed in only about 3.6 to 7% of patients with persistent masses. So already only a small number of them are actually going to have a mass. Most of these masses are going to resolve, and even of the ones that don't resolve, it's only going to be cancer at most 7% of the time. So that's good information to have and to give. What factors predict whether or not something's going to persist? Usually it's size, if it's larger than 5 centimeters, and if it's a complex morphology on ultrasound. And so when we're evaluating the adnexal mass in a pregnant woman, you have to remember that it doesn't take, within a trimester, her adnexa are no longer within her pelvis, and they're elevated outside of the pelvis because of the pregnancy. And so for that, vaginal ultrasound won't be as useful as an abdominal ultrasound, and this certainly should be used if needed. If additional imaging is needed, then we use an MRI, because with that strategy, we won't have any fetal radiation. And the MRI can be very effective at delineating whether or not there's evidence of metastatic disease and give us all the information. The CA-125 is elevated during pregnancy, and in the first trimester, the CA-125 can peak anywhere. It can be really low, it can be in the 200 levels. When you have low levels in pregnancy, the CA-125, it's usually not associated with malignancy. And if the CA-125 is a marker for a malignancy, and the malignancy is progressing, you will see a rise in the CA-125. It's the unusual woman, it would be the unlikely woman who would have an elevated CA-125, say in the 200s, and it was a malignancy and it just stayed at 200. It would rise. We do know, though, that there are some ovarian cancers that don't express CA-125. So if it's low, it's really not that helpful. But if it's high, it's helpful. And I know that Dr. Green spoke about preservation of fertility, but this is something as gynecologists, and especially as gynecologic oncologists, it's something we always have to bear in mind, preservation of fertility. And when you're having a discussion, the woman, pregnant or otherwise, about adnexal it's very important to be aware of what her plans are for her fertility and to discuss scenarios which may compromise or remove her fertility, or actually have a discussion about how radical she would want intervention to be and how much risk she'd be willing to take to preserve fertility. And this is because a significant subset of women are delaying childbearing. I mean, 28 in 1,000 women will have their first child between 30 and 34, but the rate of first childbirth over the age 40 is increased by 4 to 4%, and this is particularly so now that women are delaying childbearing to get their careers in a more secure position before they start having their family. And also, too, because there's certainly many more interventions that can be offered to women to help improve their fertility over the age of 40. And so, because of these advancements, you always have to have in mind what's the plan for fertility preservation, as it's always very tricky when you end up in a situation where it's one thing if it's advanced disease, then there are very limited options. But if a woman does have options, it's very important that she be able to state what her options and preferences are. So this slide shows the ovary. And what's really interesting, so there are different types of ovarian cancer. The one that we hear about most often is the one, it's called an epithelial ovarian cancer, and this is a lethal one. And this is the one that starts in these cells. You see that single layer of cells there? That's where the cancer starts. And it's just absolutely amazing that this just one monolayer of cells could be responsible for so much trauma and drama. There are also other types of ovarian cancers. There are granulosa cell tumors, and there are germ cell tumors. And germ cell tumors or germ cell cancers are made up of the parts of the ovary that are responsible for development of the egg. And then you actually have other cancers that form within the cortex of the ovary. But these are only a small number of the cancers. Most of the cancers begin right, oh dear, I lost my cursor. Anyway, okay, we'll go on. And what the good thing, though, is, well, I suppose I shouldn't say it's a good thing. Only about 10% of ovarian cancers are directly a result of a woman's largely the result of her genetic makeup. 90% of all ovarian cancers are sporadic. So I suppose what that means is that we don't know what specifically causes this. But you can actually see that the peak age of ovarian cancer is usually in women in their 5th and 6th decades of life. And ovarian cancer, when we say ovarian cancer loosely, we're talking about epithelial cancer. That's that cancer that starts in that lining. Their survival is not very good in advanced stages, and that's stage 3 and 4. However, if you were to find an ovarian cancer at stage 1 or stage 2, survival is excellent. And there are options for preserving fertility with the diagnosis of a stage 1 ovarian cancer. Ovarian cancer has just about the same cure rate as breast cancer, but the majority of breast cancers are found at stage 1. So we really need some sort of strategy to identify ovarian cancer when stage 1. We're not there yet. We'll start trying all sorts of exciting strategies, but unfortunately none of them are working right now. What protects against ovarian cancer? The most common thing, especially if someone's had a loved one have ovarian cancer, you wonder, what can I do to decrease my risk? Well, the good news is that the average woman has a lifetime risk of only about 1.7% of developing ovarian cancer. So that's a pretty low risk. If you have a mother or a sister or a daughter with ovarian cancer, and that's the only other person, your risk probably goes up to maybe a 4% lifetime risk. If, however, you have a mother and sister or a close relative with ovarian or breast cancer before the age of 50, your risk goes up much higher, because those are women who we're concerned that they may have some genetic contributions towards their risk. So the single, of course, removing the ovaries and the tubes, I should have put the salpingo oophorectomy, is the single best way to protect against ovarian cancer. Unfortunately, that's not a very practical option in the average woman. And even in women who are at high risk for ovarian cancer, that's not necessarily an optimal strategy, because it decreases their ability to complete their childbearing wishes. It puts them into early menopause, and with early menopause comes the risk of a shorter lifespan. And so women who are at high risk, and even women just at moderate risk, use of oral contraceptive pills is the single best thing that you can do to decrease your risk, short of removing your ovaries and tubes. And you can actually have a 40% reduction in your risk of ovarian cancer. And the next common question is, well, how long do you have to use the pill for? There have been reports of protection for as short as 3 months or as short as 3 years. Certainly you want to encourage more than 10 or 15 years of use. And if the progestin-only pill is used, there's lesser protection. Other things that protect against ovarian cancer are tubal ligation and pregnancy. What do we do to decide whether or not we think if somebody has an ovarian cancer? Well, we talked about the ultrasound, and we look at that. The only blood test that we really have available at this time is the CA-125. And the CA-125 in premenopausal women can be elevated because of a whole host of reasons. At the time of ovulation, at the time of menses, if you have PID, if you have endometriosis, you can get really high levels of CA-125 in endometriosis or endometriomas, appendicitis, gastroenteritis, and so in leiomyomas, adenomyosis, and I could go on and on. And so CA-125 should be interpreted with a lot of caution in women in the reproductive age groups. And the CA-125 is best drawn between days 3 and day 10 of the cycle, because that's a time you're not ovulating at that time. You're not going to have a corpus luteum. That's a time when your upper genital tract is probably the most quiescent, and you get a better baseline read of the CA-125. That said, a value over 54 is concerning, and there's a lot of debate about whether or not the CA-125 should be ordered in a woman with a pelvic mass who is premenopausal, in the absence of not very serious other findings for malignancy. The CA-125 should never be done as a part of ovarian cancer screening in the average woman. There's no ovarian cancer screening for women who are not at high risk. In postmenopausal women or menopausal women, a CA-125 greater than 35 is cause for concern, because at that age, at that stage of life, you're not going to have a functional endometrioma or endometriosis. Your leiomyomas are going to be quiescent, and there's a 25% chance that a woman with an elevated CA-125 is going to have a malignancy. And so we talked about the ultrasounds, and the things that reassure me as an oncologist, or allow me to reassure the patient, is if you have a cyst or a mass that has a smooth wall, doesn't have septations, and septations are walls that can form, and there's nothing solid. You have to be concerned that this adnexal mass is a malignancy if it has nodules or solid areas within it, if the walls are really thick, if you can actually see peritoneal implants or ascites. The use of the Doppler is really controversial. We usually used it a lot when I was a resident back in the 1990s. I'm dating myself, but that isn't used as much anymore. And so this is that adnexal mass. If you look at it, you can see that nodule right here. And you see how thick that wall is. All of that's concerning, and that's a very suspicious adnexal mass. And that's what we call a complex adnexal mass, because a simple cyst would just have a really thin wall that should be less than 3 millimeters. So let's just suppose it's a simple cyst. You can tell the patient that the risk of cancer is less than 1%. Observation is acceptable for pre- and postmenopausal women, and it's dependent on the size. If the patient's symptomatic, if she's having twisting pain, if she's having cramping, intermittent nausea, then the simple cyst needs to be removed. And if the CA125 if she has a simple cyst, her CA125 is elevated, and she's postmenopausal, you really don't have any way around getting past evaluation of that simple cyst. If it's a solid adnexal mass, there are lots of benign reasons for the solid adnexal mass, as I mentioned before. It can be a fibroid, a fibroma, a sarcoma, a Brenner tumor, and very many of these can be handled laparoscopically. A lot of it depends on the size of the adnexal mass and how you plan to remove it. Certainly you don't morcellate adnexal masses within the pelvis. If a mass is large and it's difficult to be removed without morcellation, then either consideration should be made to making an incision in the vagina and removing it that way. Alternatively, if the goal is to morcellate it, is to be morcellated in a bag. You put the specimen in a bag, morcellate it within the bag without spill, and then remove it. And then solid adnexal mass is what makes us as gynecologic oncologists concerned, is the fact that it could be a stromal, germ cell, epithelial cancer, or metastatic disease. And these are the tests that we'll usually do in evaluation of the solid adnexal mass. If the woman is postmenopausal, it'll be a CA125, and if she hasn't had a recent colonoscopy, a CEA. A CEA isn't screening for colon cancer, but if the CEA is elevated in a woman with adnexal mass, you really want to have her have an upper and lower, have her have an evaluation of the upper and lower GI tract, because it's a possibility that she has a colon cancer, and this is really a met to her ovary. In the premenopausal women, though, we'll get an alpha-fetoprotein, a beta-HCG, inhibin, and LH, because all of those are markers that will make you suggest that it's a germ cell cancer. And if it is, there's room for preservation of her fertility. If the patient's particularly symptomatic, a CT of the abdomen can be very helpful. And you know, there's no harm in starting with laparoscopy. Especially if you're in a situation where you're not sure if you're going to have backup or not. You start with a laparoscopy. If there's evidence of carcinomatosis, then you can end the procedure and have her referred immediately to somebody who can do a full staging procedure. Otherwise, you can just remove the mass, remove it in a bag, remove it from the pelvis, and after you get your final pathology, determine what gets done there. And so if the person has a cancer diagnosis, what we do is, at minimum, removal of that ovary and tube, pelvic and periaortic lymph nodes, removal of the omentum, washings, and biopsies, if it's a germ cell or a stromal tumor, because you can preserve fertility. You do not need to take out the other ovary. And even if there's cancer, you can see metastatic disease in the other ovary, you can core it out or scoop it out and keep the other ovary. She certainly doesn't need a hysterectomy if this is a germ cell tumor and she desires fertility, because the germ cell tumors are so responsive to chemotherapy. These women are going to do really well. If it's an epithelial ovarian cancer, though, the standard is hysterectomy with removal of both ovaries and removal of the omentum. And there are certain scenarios in which you can do the procedure in two parts if you think that it's just limited to one ovary. And how do you approach this? If the CT scan is positive, then you probably want to have a laparotomy with a vertical incision. When I say positive, the CT scan shows no mental kick, large volume ascites. That's probably somebody who needs to be operated on through a vertical incision. Otherwise, very often now, it's not standard of care, and a lot of it depends on what your surgical skill set is, but laparoscopy can be used to stage a certain subset of women with ovarian cancer. And we talked about this before, so we can go through that. What about the woman who is premenopausal, who has a complex adnexal mass? And that complex adnexal mass is something that looks like the ultrasound side that I showed you with the thick walls and the nodules, you can always do a laparoscopy if low probability of cancer. And if the radiographic findings don't have anything that's suspicious, certainly you should proceed with laparoscopy. If you think that there's a high likelihood that this is cancer, certainly if they see peritoneal carcinomatosis, that's, there are non-cancer diagnoses that give the appearance of peritoneal metastases, but those are so rare, and that would be things like coccidiomycosis or pelvic tuberculosis, but not many of us aren't going to see that frequently. But if the patient, at the time it looks like this is just a stage 1 ovarian cancer, what we do for women who we think have stage 1, we take out the affected ovarian tube, we do washings, we remove the omentum, we do the lymph nodes. Notice I haven't said anything about removing the other ovary that looks normal. I haven't said anything about removing the uterus. Have the pathologist evaluate all of the specimens, and if any of those specimens have metastatic disease, then she's more than a stage 1. And in that situation, you're going to have to remove the other ovary. But if you approach something laparoscopically, you can do unilateral salpingo-oophorectomy or a cystectomy. And of course, you always want to preserve the ovarian tissue if it's just a dermoid. And we talked about these things, so we can move on to things that are more exciting. I've also done my spiel on laparoscopic removal of ovarian cysts. Put it in an endo bag or remove it via colpotomy. You really don't want to morcellate it, because you could really take her from a stage 1 easily and make her disease widely metastatic. And so people always say, so what do I do for preoperative workup if I think somebody has ovarian cancer? Well, you probably would have an ultrasound, because very many of these women come to our attention because of an ultrasound. If she has symptoms, then you do you may do additional imaging like a CT scan. A CA-125 in the postmenopausal woman is something that should be done. In the premenopausal woman, it's controversial. A lot of it depends on what the symptoms are. And a lot of generalists find it uncomfortable, because if you do it and it comes back 200, that might be a woman who now feels that she probably needs to have more specialist care, and it may just be endometriosis. So some clinical judgment is required there. If the mass is left-sided, if she's anemic, if she's hemocult positive, she needs an endoscopy, upper and lower endoscopy, because you have to be sure that this is not a GI primary. And if we do a chest X-ray is usually actually done for part of staging, because if you see a pleural effusion and you elect to tap it, and that's positive, that would make her stage 4. And for the patients who are pretty suspicious that this is an ovarian cancer, we counsel them about bowel sections and colostomy. And this is what is required at the time of ovarian cancer stage. I mean, these pictures are a little dramatic, The picture below here is, it's a very common finding in advanced stage disease. That's a transverse colon, and that's metastatic disease. And the surgeon's goal is to remove as much of this cancer as possible. We are expected as human oncologists to make sure that there's no lesion left that's larger than a centimeter. But recently, actually, the challenge has been to see if you can actually do it so that there's no visible disease present. So this is a lot of work. This is an easier situation because you don't see that much metastatic disease. You want to completely explore the abdomen. You want to feel under the diaphragm, because you can have metastatic disease in the diaphragm. And it really would have made no sense to spend hours and hours here if she has unresectable disease that's higher up, because that patient, what you've really done is increase her morbidity. So the goal is aggressive cytoreduction, aggressive. So if, heaven forbid, anyone end up in a situation where they encounter this and a GYN oncologist is not around, the goal is to remove that cancer to microscopic disease. Lymph nodes are removed if they're more than 2 centimeters. Or if there's no evidence of metastatic disease and you're doing it as part of staging, then we remove the pelvic and periaortic. And if there was no evidence of metastatic disease, then we actually biopsy the peritoneum. The peritoneum in the pelvis and the peritoneum in the abdomen, just to be sure that there's no microscopic metastatic disease, because microscopic metastatic disease in the upper abdomen would make you a stage 3, which makes you need to have chemotherapy. So we talked about that. And so this is a beautiful pelvis, can actually look like a real mess in somebody with ovarian cancer. And this is usually, this is not an uncommon presentation. The woman actually looks pregnant. And she'll have, it's not uncommon to hear that, I was just having some vague symptoms, and then literally my abdomen just blew up in the space of a couple of weeks. They can become very symptomatic, not be able to tolerate much oral intake, be short of breath, not be able to lie down flat. It can be a really miserable situation. And ovarian cancer is the second most common gynecologic malignancy, and that's after uterine. Uterine is actually the most common gynecologic cancer. It's the however, ovarian cancer is the most lethal of the gynecologic cancers. 80% of these are stage 3 or 4 presentation. We really need to work hard at finding a way to detect it early. We have no effective screening tool. The CA-125 is not a screening tool, and staging is critical. And treatment for ovarian cancer, if the goal is to try to get to cure, the treatment is surgery and chemotherapy. Just one of those won't work. And this is the reason why the ovarian cancer can so extensively involve the abdomen. Because you can imagine if you have disease just first here on the ovaries, with the fluid that's present, fluid moves around the body in this direction. It's easy to have deposits travel to the pelvic peritoneum, the bowel serosa, the omentum, the surface of the liver, and the diaphragm. These are the most common mechanisms of spread, direct extension. Less common is pelvic or periaortic disease involvement because of lymphatic spread. And it's pretty unusual to have metastatic disease to the brain because most of the spread is just by direct extension. In women with early stage, and you can only say somebody's a stage 1A unless you've removed her omentum and you've removed her pelvic and periaortic lymph nodes. What we usually say is that of all the women who you think are stage 1, not a small portion of them, not an insignificant portion, will actually, if you remove their omentum and their lymph nodes, be upstage. So these are women who, at the time of surgery, you thought, oh, there just appears to be disease on the ovary, remove the ovary. When they go back and restage her, 16% of the time she'll be upstage. And so overall, women with 1A and 2C, up to 1A and 2C ovarian cancer, 31% of them will be upstaged. 70% of the ones who are upstage will be a stage 3 or higher. So that's why it's very important to do complete staging. Another reason that's important, because a stage 1A or 1B with a low-grade tumor, we don't give chemotherapy to. So you really need to know whether or not you need to make that, number 1, make that woman infertile, or number 2, subject her to 6 cycles of chemotherapy. I don't know why it's stuck again. We talked about ovarian cancer, we talked about the germ cell, and this is just to say again, women with germ cells, stromal cell, low malignant potential, or stage 1A epithelial ovarian cancer, these are women who can preserve an ovary. And these are your options, and that's why it's very important to know what her plans are for future childbearing. It can be something as small as an ovarian cystectomy, lateral salpingo oophorectomy, remove one ovary and remove the uterus, remove both ovaries, leave the uterus. There's so many different combinations, and it's so much easier to have that discussion pre-op because going out and talking to the family is not a good substitute. When somebody does have advanced stage epithelial ovarian cancer, the goal is cytoreduction. And this how long a person lives with their ovarian cancer is directly proportional to your ability to be able to remove as much of that cancer as possible. I mentioned before that the goal is to remove it down to minimum disease. And that's because those are the women who you can leave with no visible disease. those are the women who you're going to be able to, who have a chance of cure. And they've done studies on this, and these are what we call survival curves. And so this is how big the tumors that were left behind were. So microscopic, because you can't get everything out, right? Because you can only remove what you can see. So the women who had microscopic disease left at the end of their surgery, they had the best survival. These curves down here are not so hot. These are women with disease left behind that was greater than 2 centimeters, and they had the worst survival. I want to make mention of the fact that there's something called low malignant potential tumors. And low malignant tumors are also called borderline tumors or atypical proliferative hyperplasia of the ovary. And these are women who, if they have advanced disease, they can be symptomatic, and it can look a lot like that slide I showed you with the tumor all over the transverse colon. It can look pretty similar to that, and really take the pathologist to tell you what it is. The good thing is that women with advanced low malignant potential tumor will do well. The goal is to debulk or remove as much tumor as possible. In these women, you only remove the lymph nodes if they're enlarged. There's no benefit of chemotherapy or radiation therapy. And if you're ever in a situation where the pathologist can't, on frozen section, tell you whether something is a borderline tumor versus a cancer, it's just best to be conservative and do the smaller surgery, because you can probably go back laparoscopically and finish off what else needs to be done. We no longer give chemotherapy except in the women, some of the women with micropapillary architecture. There's some debate about whether that might be a subtype that may be a little bit more aggressive. But overall, patients, there are more deaths from treatment of low malignant potential therapy. So the goal for those is surgery preservation. I'm sorry, ovarian preservation. And ovarian preservation, the common question is, what's the chance of this becoming a cancer? And to date, we have no evidence that low malignant potential tumors are the step before ovarian cancer. We really don't know what the step just prior to ovarian cancer is. We're not in the science of ovarian cancer. We're not in the same places we are with colon or the cervix, with being able to identify the precursor lesions. But to date, there's no evidence that low malignant potential tumors are this precursor. They do spread, though. That said, the 10-year survival is 90%, which is excellent. Overall, most of them are stage 1. It's rare that you're going to find something that's not. And less than 1% will actually become malignant. We talk about ovarian preservation in women with germ cell tumors. Excluding the stage, in women with germ cell, we have an excellent cure rate. We have a 75% cure rate with advanced stage disease and 100% cure rate for early stage disease, even if we leave some tumor behind, because these tumors are very chemotherapy sensitive. When we talk about malignant sex-scored stromal tumors, adult granulosa is more common in postmenopausal women. But even so, the juvenile granulosa cell tumors, we have a 90% cure rate. If they relapse within 2 years, those women can have a poor prognosis. But we treat the advanced or recurrent disease with platinum therapy, so that's a good thing. And I will end there. We've sort of been on the telephone now for just about an hour, and I will have David take it from here. David?
Okay, can you hear me?
I can hear you.
Great. Okay, thanks, Wendy. I just wanted to let you know that I was kicked off the internet, and I've been trying to get back in, and it just didn't work. So I've been flying blind. I'm actually calling in right now. So Sherry's going to take it.
Oh no.
I know. But since I have the slides, I can follow you, along with you as you were speaking.
Oh.
Sherry will ask the questions, if that's okay. And folks, remember, there's a blue panel to the upper right hand of your screen, so you can type in questions in the chat box. Okay. Wendy, again, thank you for this presentation.
Oh, my pleasure.
I think it's really, really good news that there's a 10-year survival rate now for ovarian cancer. I have before I ask Sherry for the questions, I've always been interested in how one thing or a lesion in one part of the body affects a quote-unquote unconnected part of the body somewhere else. And so my question is, with ovarian cancers, for instance, what are you concerned with? I mean, are there any other systems? I know, okay, we know about metastasis, but any other systems, because ovarian cancer deals with the ovaries deal with the endocrine system, for instance. How does that change the balance in the body? What are you concerned about the most?
Well, in postmenopausal women, when a woman goes into menopause, she has production of testosterone for a few years after menopause, maybe as many as 4 years. But outside of that, the ovaries aren't producing, they're not producing estrogen, they're not producing testosterone, and actually testosterone is produced in women at this point in their life by the adrenal glands. And so removal of the ovaries will not have the same effect in a postmenopausal woman as it was in a premenopausal woman. And so the challenge in a woman who's premenopausal, if you remove both her ovaries, is the fact that you've put her in menopause very abruptly. And women who have to make that abrupt transition to menopause, that surgical transition to menopause, can actually have a rockier time adjusting. And so those are probably the issues. When somebody has ovarian cancer, many of the challenges are related to spread of disease to other organs. And so commonly within the pelvis, you have to be concerned about disease of putting pressure or invading the rectum. And that's why very often the consent form will say bowel resection or it'll say colostomy, because that might be what it takes to actually remove all the cancer, or that's what it may take to preserve the use of her intestines, because you have to be able to eliminate waste. Oftentimes, not often, but sometimes you can actually have diseases involving the spleen, and that may require removal of the spleen in order to do what I discussed, optimal debulking. And in that situation, we have to be mindful of the fact that she needs to receive her influenza vaccine and her pneumococcal vaccine, because women who don't have a spleen are more susceptible to those diseases. And then if there's disease to the liver, we have to decide whether or not it's resectable or not. So those are the general organ systems more commonly involved.
So there isn't much connection between osteoporosis and ovarian cancer?
Well, if you remove a woman's ovaries premenopausally, you put her at risk for osteoporosis. You put her at risk for osteoporosis, for heart disease, but you're really in a tough situation there, because the option of leaving the ovary with cancer is really not a feasible one. And so it's sort of a matter of weighing risk and benefit. And so you know that you're going to have the challenge of making sure that she has appropriate supplementation in her diet to prevent osteoporosis, making sure she exercises, and make sure that her cardiac health is good. But usually if you have to remove both ovaries in a premenopausal woman, you're in a really tough situation, and leaving the ovaries won't be an option.
Supplementation, you mentioned that. What is your take on that for people with your patients? Do you generally recommend supplements for them?
When you say supplement, you mean estrogen supplementation? Estrogen therapy?
Yes, I understand that.
Symptomatic.
If she's
symptomatic. If a woman is young and she's symptomatic, and what symptomatic? Symptomatic means having, more than 7 hot flashes an hour. If she's unable to sleep through the night because her sleep's interrupted, then she needs some sort of intervention, because you need to have uninterrupted sleep if you're really going to have good mental health. And so in those women, some sort of guidance is going to be needed. With regards to other supplements, I recommend that when women are going through chemotherapy that they take a multivitamin. I am not in favor of the overdosing of any particular mineral or vitamin, because very often that can have its complications also. And the goal is moderation and keep things in balance and try to have a healthy life from that point on. Can't really change. You can't change what's happened before. We have to decide how you're going to move forward and what your approach is going to be.
Well said. Well said. Thank you. Sherry, go ahead.
Yeah, there's a couple questions, Wendy. There were a couple people were asking, what is that CA-125, and is it a marker in women that's similar to the PSA marker in men with prostate cancer?
It's a similar marker, but the CA-125 is a cancer antigen 125. I think it was the 125th one they tested. But it's elevated in women with ovarian cancer. It's also elevated in multiple other conditions. It's elevated if you have metastatic disease anywhere within the pelvis, you can have an elevated CA-125. If you're on your period, if you have fibroids, if you're pregnant, if you have appendicitis, if you have gastroenteritis, diverticulitis, any host of things can elevate the CA-125. So it's not as good a test as the PSA is. It's a test that we have, and it's a test that we use, and we just have to be mindful that there are limitations. And so if we know that a woman has a cancer, we check the CA-125 because we know we can use it as a marker. Because if it's elevated, it means that we can use that to determine if the cancer comes back. Or we can use it to see how well she's responding to chemotherapy. If it's not elevated, it's not that useful, and not all ovarian cancers will make a CA-125. So we're looking for better tests, and there are lots of studies in the literature about using combinations of tests. Because I think, I believe that in ovarian cancer, we're going to end up having to use multiple markers, not just one marker.
Somebody asked too, would ovarian cancer be felt in the vagina, and does it make sex painful?
It can be. When women complain of painful sex, it's usually more likely to be something related to endometriosis or fibroids. But you can, when my patients come and I do a physical examination, if they have metastatic disease, it can be palpable. But ovarian cancer isn't the only thing that would make sex difficult, or ovarian cancer isn't the only thing that would make a mass palpable on vaginal examination. It could be any of the other two I mentioned.
Okay. On this chart showing the stage and survival rate, the question is, does it remain constant even if a woman's postmenopausal? So the question said, on the chart showing stage and survival rates, does this remain constant even if a woman is postmenopausal?
Yes. Those are the survival rates overall, so they include women who are pre- and postmenopausal. There are women with mutations. I didn't discuss this, but there are some women who have BRCA1 or BRCA2 mutations. A subset of those women actually do have a better survival for ovarian cancer. But overall, yes, that's a cure rate whether or not you're pre- or postmenopausal.
Okay. And we just have one more question here. I know it's getting late where you are. Let's see. It says, on the 10-year survival rate statistics, what is the quality of life if, say, a woman is 73 years old versus 53 years old?
Oh, wow. So that's, what is a 10-year survival on quality of life?
Yeah, it says on the 10-year survival rate statistics, what is the quality of life if a woman is 73 years old versus 53 years old?
Okay, so the ability to, the women who you're going to be able to cure, who you hope that long-term you're going to give them a great quality of life, are women in whom you can get the disease down to microscopic, and the women who you can give them the full dose and number of cycles of chemotherapy. And so it can be challenging in older women. Because say you have a 73-year-old diagnosed with ovarian cancer, if she's in great health, I mean, 73 can be, you can have a 73-year-old woman who's going on 60, or you can have a 73-year-old woman who's going on 83. So if she is in good health and doesn't have any medical conditions that limit your ability to treat her, we'll treat her like she's a 50-something-year-old. If, however, she has issues, say, related to heart disease or lung problems, then you may not necessarily be able to give her, you may not be able to as aggressively treat her. Quality of life is very important. Quality of life while you're getting therapy is important, and quality of life afterwards is. And we try to preserve the definition of quality of life is often the patient decides whether or not she thinks she has a good quality of life. And quality of life can be judged by whether or not you'll be able to perform your regular activities of daily living or do the things you enjoy. I mean, being able to care for yourself in your own home without any assistance. And so the bottom line is a 10-year survival for a 73-year-old versus a 53-year-old. If you can treat them equally well, they'll do just as well. If, however, the 73-year-old is an old 73-year-old, your chances of being able to cure that woman is a lot lower. And so what I tell my patients is, we'll do the best surgical effort we can, and we'll give chemotherapy. And if you cannot, because you're not going to know whether or not you're going to be able to tolerate chemotherapy just by thinking about it. I mean, you can look at somebody and make some assessments, but really it's going to depend on how they respond. And if it's not going well, you can always stop. But you would hate to have not tried and not given the person the opportunity.
But I think that's pretty much the question, David, if you want to.
Oh, good.
Okay, great.
Thanks, David. Thanks, Sherry.
Hey, Wendy, thank you. Sherry and I have been typing back and forth, and I was saying.
You have? I haven't seen the chatting.
Oh, we excluded you, and basically it was all about your voice. We were like, wow, you have such a beautiful voice. I mean, if I didn't know anything about medicine, I would still love to listen to you speak.
You know what? I didn't end up with a bad accent. There are some nice accents out there. But anyway, it was a pleasure to be able to participate, and I thanks all the 18 listeners who are still out there.
Well, thank you for hanging in with us, too. We appreciate it. Next time, we'll start at 10 p.m. your time. How about that?
10 p.m. start?
Yes.
No. Next time we start at 5 p.m. my time. Anyway, I'll take care.
All right, you take care, too. Thank you so much.
Bye-bye.
And folks, thank you for hanging with us, and we wish you a great evening or afternoon or morning, as the case may be. We'll see you next week. God bless.